happy to be here today, and thank you all for attending. Which one? And I apologize for the spelling error on the first screen there. Barry is correct that universal screening of infants right now is a pretty controversial idea in various parts of the world, and I'm getting a little bit of a complex about that because every time I've noticed that in the last 3 years I've given 7 talks now with the word controversy associated with that. So, and Helen is also correct that this is an idea that just makes obvious sense. And what we've learned from Dr. Li-Hong Li, and also what we're going to learn from Omer, is that there's tons of pathology that's out there to be seen. And what we've learned previously from Helen is that when something new comes along, is that you have to study it in a rigorous manner, like what she did with the BeatROP study. And so at Stanford, I've been doing the SunDrop screening, which is the Stanford University Network for Diagnosis of Retinopathy of Prematurity, for 7 years now, which is a telemedicine outreach program. And when I started seeing Dr. Lee's data on this, it just made sense to us that we would want to go ahead and evaluate how to do this. But it being Stanford, how do I advance this? Just with the
mouse.
The mouse. It's too easy, I guess.
Just click. Click anywhere.
Can I clap?
No.
There we go. Thank you. So I went and pitched the idea to Stanford, kind of like you're pitching for a business or a bank for a loan. And I said, hey, this makes sense, just kind of like what Helen said. And I said, what is it? I said, well, we're going to go and get these digital fiber optic images of the babies before they get discharged from the hospital. In the United States, if you're born vaginal delivery, you're in the hospital 48 hours. If it's a C-section, it's 72 hours. So we want to get that image within the first 48 to 72 hours, because once the baby gets home, nobody's touching it. You got to get between the baby and the mom, and good luck on that one. So the images have to be performed by someone who's experienced in this, and we've learned that you can easily do this with trained nurses, even technicians who aren't nurses. The images can be read by, in my situation, a pediatric retina specialist, in many of the situations, pediatric ophthalmologist, but someone who has experience in looking at retinal findings. And then, most importantly, what do you do with the data? It's not so important just to collate, hey, here's all the bad stuff we find, okay? But we can actually do something about it. And that's the question. Can we do something about it? In the United States, oops, I went the wrong way. The first formal screening really occurs between ages 5 and 6 by the time the child hits kindergarten, okay? And last year, in January of 2011, the United States Preventative Task Force evaluated screening mechanisms for amblyopia strabismus and basically said, hey, it's not worth your time or money. And this caused a big uproar in the United States because they're saying, we don't care if you find the disease, because everything that you do to change that disease at that point in time is worthless. That was their reading of all the literature, because if you see a child with a 40 prism diopter angle at age 3, it's unlikely you're going to improve that child's vision, is what they said. But if you actually go and delve deep into it, they only looked at data between ages 1 and 5. They didn't look at babies less than 1 year, okay? And in fact, we're not talking about screening babies less than 1 year. We're talking about screening babies less than 1 week, okay? Because as a pediatric retina surgeon and a pediatric ophthalmologist, we can tell you that if you have monocular occlusion for longer than 12 weeks, that eye's done, okay? You can take that eye off. You're gonna have amblyopia and strabismus in that eye unless you have intervention from above, and if you know how to get that, let me know, okay? So in America, we have a 2 to 4% incidence of amblyopia, which is vision loss from some unknown cause. And oftentimes, when you look at this, and Omer is going to show a nice photo of resolved macular hemorrhage, the hemorrhage goes away. That's great. And if you never saw that hemorrhage in the eye, you look at that kid at age 3, you will see central geographic atrophy. It may only be in a paracentral. It may only be 50 microns in size. But you wonder why that eye's got a 5 prism diopter shift, or why that eye is only 20/60 as opposed to the other 20/20 eye. That's what's going on. We know in eyes in adults, when they have a subfoveal hemorrhage, that if you don't clear that out within 1 to 2 weeks, That vision is gone in that eye because blood under the retina is a toxic substance. And is it from the blood or is it from the iron? Most likely it's from the iron or the breakdown products. But we know you have to shift that out. And so this is, I'm going to see if I can make this work now. There we go. So what we've known is that functional changes, meaning how well you see, they're trailing indicators. If you test a kid and they're legally blind at age 5, there's not much you can do to help that kid. I mean, you might be able to improve them to 2100, but who cares, okay? This is the way it's usually evaluated in the United States and around the world, and it's got little proven benefit in children less than age 3 and no proven benefit in children greater than age 3. And you might be able to improve some vision up to age 12, but then again, you get 25% regression rate. So what we're saying is that if you institute screening, you're going after anatomic changes, which are leading indicators, okay? You got a submacular hemorrhage, you got a medial opacity, you have a vitreous hemorrhage, you have a tractional retinal detachment, you have a coloboma. In the case of a coloboma, you can't do much, okay? But in all of the other cases, you can have a surgical intervention that can result in a profound change anatomically that can result in a functional outcome. I can show you case after case after case of kids that I've been referred for various reasons that we've intervened on, and they've done very well, better than one would anticipate. Now, we also, as I mentioned before, know that irreversible amblyopia occurs by 8 to 12 weeks when you occlude the visual axis, and that you have incidence in American populations in small series of retinal hemorrhages of approximately 33%, ranging anywhere from 20 to 45%, but on average about 33%. And the hemorrhages usually spare the macula, and we have often said, hey, if you're sparing the macula, there's not really a bad outcome with respect to vision. We don't know that. This is just supposition, you know? And oftentimes you have these kids later on, they're age 5, and if you look at the fundus and you're gonna see some, you saw from Dr. Lee, she showed those images, even if it was sparing the center of the fovea, it would be very interesting to do to see what the functional outcome is in that child by age 5. Maybe they have just generalized decreased vision. And that's kind of where the argument has to be made. These hemorrhages are more often occur with vacuum delivery and more often with vaginal delivery than with C-sections. So at Stanford, I've had to arm wrestle with them. I can't go out there and start screening babies. I have to get an institutional review board approval because we're going after a grander thing. What I have always advocated in the United States for ROP screening is that we have to be like what they do for the hearing tests. And I often say this when I'm doing ROP talks. If you have a baby, and my children were born at Stanford Hospital, at Lucile Packard Children's Hospital at Stanford University. If you have a baby and your baby is actively bleeding, you can leave the hospital. No one's gonna stop you, okay? But if your baby didn't get a hearing test, the CIA and the FBI and everyone else is gonna hunt you down and you'll get tackled on your way out of the hospital, okay? And the reason for that is it's mandated in all 50 states that you have this. It's a federal, it's not a federal, it's a state-by-state regulation that you have this. And the same thing for those inborn error of metabolism testing that Helen mentioned on the original screen. And what I want to do is evaluate, can we actually prevent visual or decrease the amount of vision loss such that we can bring about a screening requirement for these children. And to do that, we have to have a prospective study. So we're in the process. We have our IRBs actually looking at this right now. Obvious things to look for, as Helen brought up, were cataract, vitreous hemorrhage, congenital glaucoma. Less obvious things, coloboma, retinoblastoma, hamartomas, nerve abnormalities, fever, stuff like that. But obviously, the big one is going to be hemorrhage. We've seen from the studies coming up, and what we'll see that was just presented, is that you get hemorrhages in up to 20% of babies in different national populations. You get up to 3% other ocular abnormalities. And this is important because at the end there, I heard Dr. Lee say that 2.1% of babies had other abnormalities other than retinal hemorrhages. And that 2.1% is secondary to the 20% of hemorrhages, okay? Now, to put this into comparison, remember what I said, that all 50 states require screening for hearing tests? Well, the screening, the chance of finding a hearing abnormality in a high-risk population, a high risk, a known family history of deafness, is only 5%. okay? And yet it's mandated that you screen. Now, we know from statistics for a screening test to have any utility, okay, on an economic basis, is it worthwhile to screen the entire population? The optimum rate of incidence of disease is 2%, okay? That's what you want to have. If you're at 2%, the screening pays for itself because they're going to get plugged into the system. Now, again, the only way that makes sense is if you can actually change the course of the disease. In a coloboma, it's not going to matter. But maybe a coloboma tells you the kid has a heart disease or they have an atresia somewhere else in the body. And so that kid's going to get looked at for something else, and you're going to get the kid plugged into the system earlier than you would have. You may not have been able to save the eye, but you may be able to save the kid, which, you know, is something good also. So you are already surpassing the requirements for a screening test, which is that you're above the 2% level with 3% ocular abnormalities, and then with the hemorrhages, you're at the 20% level. Let me see. This way. So these are the hemorrhages that she showed previously, Dr. Lee. And so what do we have? You know, we now have 6 RET cams in 6 different hospitals. We have a live captured birth population, which is tiny by Chinese or Brazilian standards, of about 4,500 births per year. But in all the hospital systems, we're approaching 20,000 live births a year. And then these are just kind of the breakdown of our Sundrop network. We already have the telemedicine infrastructure. In the United States, everything is made more complicated by the fact that you're going to get sued if you're wrong, okay? And you're going to end up paying a lot of money for that. And so we have to have, and it's not even that you're wrong, you just have to, even just transferring the information from one physician to another. Like I saw Omer, he's got all these beautiful images on his iPhone. To get into my iPhone, I have to type like a 25-digit code that Stanford gives me. And even then, they have the ability to remote wipe my phone, and I can't keep the data on my own phone because of all these laws that they have in the United States, which is something that I appreciate that you guys don't have to deal with as much in the rest of the world, but it's coming, believe me. Ooh, the video's working even. And so this is an old video that we use for ROP. This is a nurse showing the very first time. She's never taken an image before on a live baby. And as you can see, she's screening here for ROP, but it's just so evident that, you know, even with this relatively heavy handpiece, this is the old metal one before they have the lighter weight plastic one, that she's able to get a usable image right there. I can say, okay, this baby does not need ROP treatment. And if I were screening for other diseases, I would be looking for, you know, how's the macula look, but I'm going to see that in a second. I can see the foveal reflex is intact there, which is actually kind of interesting in a premature infant. But you basically offer the family a fee-based service initially. Hopefully you could get it paid for by insurance down the road. You get photographs, you get an interpretation, we send the report back. You either enter them into the system for follow-up as appropriate, or you send them on their merry way. These are the standard protocol photographs that we use in ROP. I think they'd be entirely appropriate for newborn screening. You get an external view. It lets you know if there's an iris abnormality, a lens abnormality, a corneal abnormality, and then you get your wide-angle views of the fundus. Right now, we hope to have approval from the Institutional Review Board at Stanford by October 2nd. We have funding in place from an outside grant source to hire a full-time nurse. Initially, we'll use their 50%. We have a secure database. We want to get prospective data on up to 50% of the babies born over the first 12 months, and then 6-month outcome based on the functional values. We'll have 2 pediatric ophthalmologists plus myself, so a total of 3 screeners. We can do same-day interpretations. And by year 3, we hope to have 90% of all infants screened at the 6 hospitals. Cameras are already paid for, fortunately, because we already have this other system in place. We already have an existing infrastructure for telemedicine. And then the only thing that we'd have to do is get a nurse and then negotiate what the physician fee would be. And then the photographic fee would also include market research. So, in summary, there's a large market for this. In America, screening for retinopathy of prematurity, 80,000 babies a year, okay? Screening all babies, 4.2 million live births a year, okay? It's an unmet, unrealized clinical need with a large potential to impact and possibly decrease or halve the rate of amblyopia, preventable vision loss, with many numerous treatable conditions, and we can, go ahead and leverage our existing leadership in these areas, and that's what we have. Thank you for your time.